Why is it difficult to diagnose and treat? And this is a big challenge actually to address, and I'm sure that many of you in the audience, both patients and relatives of patients, have had the experience where you've had difficulties in your journey towards getting the diagnosis. I say challenging because there's so many pitfalls and so many hurdles to map out along the way. And I would also like to add to the title the word suspect. So why is it difficult to suspect, diagnose and treat pulmonary fibrosis? Because if we think of it like that, we can then look at the map and identify areas and opportunities where we can identify lung fibrosis a little bit earlier. So what we'll talk about is how to suspect lung fibrosis a little bit earlier than we are at the moment. We'll look at the referral pathways in, we'll look at the diagnostic processes, who and where and how this happens, what are the treatment strategies that we can employ, and what are the drug options. And I'll really just touch on these hopefully quite briefly. So first of all, let's look at the map of the key periods in lung fibrosis. We see here that there is a silent period. Here there are no symptoms, the patient has no problems, but we know that this period is actually quite critical to the run-up to lung fibrosis. And we know that if you look at people who have had scans for other reasons, for instance, CT scans of their tummy area, which pick up the bases of the lungs, CT scans of the heart, or CT scans of the chest that they've had for other reasons, you can incidentally pick up lung fibrosis. And in some countries, in the Far East, in Japan, in fact, there are screening programs for cancer where up to 10% of these populations have actually got lung fibrosis, and they have a high risk of progression over the next 2 years. So that's one really important group to target. The second group to target, and remember this is the asymptomatic group, are people who just go to the GP surgery or go and see a doctor, they have an examination of the chest with a stethoscope, and we hear these very characteristic fine Velcro crackles at the bottoms of the lung. And we know that this is a very early key sign of lung fibrosis and should prompt a referral to a chest physician who's got an interest in the area. But often these crackles are mislabeled as heart failure or perhaps another condition called bronchiectasis, and the diagnosis does not get picked up. So that's a very interesting area, and I know that Sophie's just mentioned that there's a lot of research in Southampton ongoing into novel methods of picking up these sounds. And the last group I want to mention is familial disease. We are increasingly aware that there are large numbers of genes that may be involved in lung fibrosis. There's a big national genomics project looking at familial disease, and I think for future this is a group that we will be targeting. So yes, we have a silent period where at the moment we don't really have a strategy to pick up the disease, but then we have a symptomatic period. But unfortunately, we know that there can be a 2-year period where there are symptoms and no diagnosis. So why is this? Well, the problem with the symptoms is that they're very insidious. They creep up very, very slowly, and you get unexplained breathlessness, which actually the patient can adapt to very, very easily and just downgrade what they're doing. You can have a non-productive cough. In about 80% of people, this cough can be very, very nasty, very intrusive. So both of these symptoms are very non-specific. They're very difficult for the patient themselves to self-diagnose as lung fibrosis. You may go to the GP or a doctor in the community who runs breathlessness clinics, and if you're a smoker or an ex-smoker, quite often the label will be COPD or emphysema, and that's because they will do some basic measurements of the lung function, such as spirometry, or perhaps they'll also do a chest x-ray, and they may get the impression that you have got a predominantly smoking-related lung disease and will not think of the label of lung fibrosis. So there can be a delay of 1 to 2 years before you get the diagnosis. Now, some people have breathlessness, but they also have features that are quite obvious. They've got arthritis or they've got a skin rash, and that sets the problem into context. And that pulmonary fibrosis we will then know is due to an immune problem with the joints or an immune problem with the skin, and those people tend to get picked up a little bit earlier. But if you have IPF, idiopathic, obviously the cause is not known, then there can be a delay. Now, even after you've had symptoms and you've been seen in primary care, that's your GP, or perhaps in a local hospital, you can still have a delay in referral to the specialist centre, and I think this is a topic of key concern. We know that if there's a delay to the specialist centre, this can impact on the outcome of the patient. And this delay can be anything up to 1 to 2 years as well. And the impact on the patient and the outcomes is probably as much due to diagnosing the disease, but also due to not attending to the other problems that occur in lung fibrosis. For instance, risks of infection, risks of clots in the lung, risks of all sorts of other problems that are important to pick up. So if we look at this gentleman, this is a case that was presented in the Daily Mail 5 years ago. Many of you might remember this article. This gentleman was kind enough to publicise his problem and increase awareness of lung fibrosis. I think this gentleman's experience exemplifies some of the problems with the pathway in achieving a diagnosis. So this gentleman had breathlessness. It was the only warning sign that he had. And he had a label of asthma first. He was then referred to a cardiologist before he was then referred to Dr. Joe Porter at University College London for diagnosis and treatment. And the article also highlighted quite eloquently that GPs find this condition difficult to pick up. They find it difficult to spot, to identify, and part of the problem is that there will only be a handful of cases in every GP practice in the country. Although there is a rising incidence, actually for the GP, it's still quite a rare occurrence and it's not at the forefront of their mind. So once the GP has a breathless patient, it's quite unusual for them to refer into a specialist centre. They will go first to a local hospital, a district general hospital, and then what happens to the patient? What is the pathway thereafter? Well, I think this can be variable. Ideally, the patient should go from the local hospital down to the specialist centre in a network that we call a hub and spoke model. And that means that the local hospital has a special connection with a specialist centre. This centre has assembled a team of professionals that are interested in lung fibrosis and are used to looking after them. And from there, they get their diagnosis and their treatment. And the treatments are often treatments that NHS England have commissioned the centre to prescribe. And so there has to be this flow of the patient from regional local hospitals down to the specialist centre. But better still would be if there is a referral from general practice, from other specialities and from the community directly into the specialist centre if they have a CT scan that looks like fibrosis or if they have a strong suspicion, because in that way we can streamline the pathway. So streamlining this pathway, also having earlier detection, perhaps more education and self-reporting, and improved partnerships of the local hospitals and primary care with the specialist centres is really key to the flow of the patient towards getting treatment. Before the patient gets treatment, clearly they need to have a specific diagnosis. Unfortunately, at the moment, there is no one single test to tell you what type of lung fibrosis you have. And Sophie has very eloquently described the many different types of fibrosis that you can have. In fact, there are over 300 different types that you can pick on. So we don't have a test. So you have to go through a process, a rather in-depth process where you get asked lots of questions, you have an examination and very many tests. And part of the test may be quite interventional. For instance, you might have to have a lung biopsy. Now, the lung biopsy that you have is a surgical procedure, and many patients don't want to have surgery. Many patients are not fit to have a biopsy for the reasons that the general anaesthetic may be too dangerous. And there are some specific risks associated with biopsying patients with suspected IPF. So in reality, very few patients actually get to have a biopsy, and very few patients have that data to put into the mix. There are some newer techniques such as cryobiopsy, but they're not freely available at the moment. So this is the diagnostic workup that we have, and this is mapped out by the National Institute of Clinical Excellence, or NICE, into this flow diagram, and it's really just to show you the sort of steps that you're supposed to go down. These are minimum standards that centres should have, and at the core of it is this group called the Multidisciplinary interdisciplinary team. Now, this composition, the constitution of it, is also defined by national bodies, professional bodies, and we should be having an ILD or a lung fibrosis radiologist who's expert at looking at the scans, a pathologist likewise that's expert at looking at biopsies, a clinician who's interested in fibrosis, a nurse and a coordinator are key and essential. And this group of people all sit down and talk about the case. So, and I just should add there that there are now novel ways of interacting with this MDT meeting where local hospitals can get involved directly by teleconferencing in, or by video conferencing in, or in fact by attending in person. So this is a really robust discussion of each case where we can thrash out different issues. So how does this group of people get towards a diagnosis? Well, we've heard that it's a very broad term, it's a very big umbrella term for hundreds of different types of disease. But broadly speaking, the aim is to separate out IPF from non-IPF. And the reason is that although there's hundreds of different types of fibrosis, there's actually practically only a few types of therapeutic options, and one of those is antifibrotic therapy. And at the moment, this is only licensed for use for idiopathic pulmonary fibrosis. So that's why the strategic approach is very much aimed at separating out IPF from non-IPF in the MDT. Now, it might seem easy to do that, but in fact, it's not easy to do that. And even though people have a CT scan, and even though people may or may not have a biopsy, actually these pictures can be quite challenging. And we know, in fact, that less than half of patients with IPF have a typical scan. We know that very few people have a biopsy, and we do have guidelines, but in fact the guidelines are just that, they're just a guide, and they do not cover every eventuality, and in fact they miss out this particular group who have not got a typical picture and have not got a biopsy. So this is where the MDT comes into its own, and it's an invaluable group of people discussing the case and refining and excluding other causes of fibrosis, so that you can clearly at least obtain a working diagnosis of either IPF or not IPF. And this is important for management strategies. One extra dimension to this in that difficult category is looking at how the disease behaves over time. So we don't just make a diagnosis on one snapshot of data, we look at how the disease is behaving, and this can be very, very important for people who have not got a clear-cut diagnosis. And so what will happen is that although we have this category here where they're very certain IPF, and this category here where they're everything else, we will have a sort of grey area of IPF here, and we look at the disease behaviour, and we may take the case back to the MDT and get towards this working diagnosis of IPF. So what does that mean for the patient? Well, it's difficult. We need to have some guidance on treating these patients, and this is why there is a big European Respiratory Society task force group that's ongoing, looking at trying to refine some sort of pragmatic guidance on how to look after these patients who haven't got clear-cut imaging or haven't got a clear-cut biopsy. And this is very much involving patient focus groups so that they can look at all sorts of issues of concern, for instance, communication, advanced planning, palliative care, pulmonary rehabilitation. But one very important area is what, from the patient's perspective, is important in the outcome following a treatment. And there's no real good tool or instrument to evaluate this specifically for IPF. And this is actually being developed in the form of a patient-reported outcome measure, or a PROM, specifically for IPF at the moment. And I think this will be really important data to give patients a voice in what they want from their treatment as well. So looking at the treatments and the management approaches, what are the options? Well, the first and the very most important thing is to do nothing, perhaps. We may be monitoring the patient, and this may include a group of patients who in fact don't want to have treatment, or perhaps have got very early disease, or perhaps who do not fit treatment criteria. So that's a very important category. The two other categories I want to talk about are firstly for patients who have idiopathic pulmonary fibrosis. We don't know what causes this disease. It's probably multifactorial, but what we do know is that the predominant process is fibrotic. So the plan or the aim is to slow the disease down. We cannot reverse the damage that's already done, the honeycomb structure that's created by this disease, the loss of architecture cannot be reversed. So the only thing that we can do is prevent further damage, and this is the role of the antifibrotic agents that you'll hear about later on. In the other group, that is everything else, we do often know what the cause of the disease is, and we do often know that it's inflammation that is the initiating agent and that is driving the fibrosis. And so the treatment is very different. The treatment is aimed at suppressing the inflammation, either by using steroids or by suppressing the immune system with immunosuppressants or biological agents. And it may be in future, over time and with clinical trials, that antifibrotic agents may also be used in this group, but at the moment they're only licensed for IPF, and we can't lump all fibrosing lung disease together, much as we'd like to at the moment. Vital to the management, vital to the treatment that we give patients is obviously close communication with local hospitals and GPs, because these are difficult drugs, and the primary carer, whether it's the GP or your local hospital, has to be closely involved in the management, the monitoring and the follow-up in conjunction with the specialist centre with these drugs. I just want to touch on finally about treatment. When should a patient be treated? And this is a question that patients often want to know. Why do they have to be treated right now, and what's their chance of progressing? And we know specifically for IPF that it's a very heterogeneous disease. That means that there are very many different types of patient disease behaviour within IPF. Some people can be very stable and follow this very nice flat line here. Some people can slowly progress, but some people can have a more aggressive course. And right at the outset, there's no clear predictor of how a patient is going to progress. We have some predictors of very poor outcomes, but we don't have predictors of loss of lung function. And this is where biomarkers will be very useful, and we can individualise potentially treatment for each patient into people who are going to progress very quickly and people who may progress very slowly. But actually, the timing of when we treat at the moment is very much dictated by by this national body NICE. And there are two statements that have come out, both for pirfenidone and more recently for nintedanib, showing us when we can use these drugs. And in fact, at the moment, what's clear is that we can't use these drugs for very severe disease, and we can't use these drugs for very mild disease, or indeed for people who have lung fibrosis and who smoke and who have got very large lungs. So the restrictions really are set for us rather than on us deciding. So I'd like to just summarise by saying we've discussed the difficulties in early detection. We've looked at some referral pathways in. Perhaps they're not ideal at the moment. We can debate these. We've looked at the role of the multidisciplinary meeting in our hub and spoke model, and we've discussed some of the treatment strategies that we have available. Thank you very much.